Good evening, gentlemen and ladies. I will be presenting EPVAR at something which is catching on. We got a great device with us, the ProGlide, and we've been using it for our routine angios, angioplasties, wire bands, and for local groin exposures. But I think we've sort of moved on to aneurysm care. We had used it in 3 patients. The first one was, I think, around 6 months back. Second one, I think, around 3 months, and last one was barely 15 days back. Just a brief overview. We start off with the first device. It's usually a 6 French sheath. It's totally percutaneous, can be done under local anesthesia. And the whole procedure, the whole thing can be done under local anesthesia, ideally in obese patient, but and every patient is suitable. If you have a suitable femoral artery, you got the right patient for this. First device is usually at a 10 o'clock position. Basically, if you look at the clock and it's pointing towards 10, it's around 30 degrees to the left or on the lateral side. And once you got the retrieved the suture for the first, it's a very standard deployment for as for a 6 French sheath. Then you go on to the second side, and this side you're 30 degrees to the medial side, and exactly the same procedure. Just be careful once you're introduced it. When you're introducing it, it should be at 12, and then rotate it inside to 2 o'clock position. And retrieve the sutures, hold it with a clip on both sides, just leave it there, make sure you don't pull the thread too much. That's something which needs to be taken care of at this stage. I think the most important step at this stage is keep some mops over it, make sure you don't pull the thread at this stage. Put your bag, and the best part about this ProGlide is you can have your vessel access at every time and any time you want it. And you remove your sheath, tighten the sheath. When you're done with the final procedure, when you're removing the sheath finally, tighten the first suture first and the second one second. So I think that's more important, that the lateral one first and the medial one later, or whatever procedure you followed the first time around. So then tighten second suture in off. Not great pictures, but basically this is deploying our first ProGlide, and we're doing a thoracic aneurysm. So we're just using the right groin, the left groin is just a normal angio. So we're doing the right groin first, and a huge lady with a huge pannus, and unfortunately, ladies with big pannus are an issue with ProGlide, and I think there's a lot of lessons to be learned later on, which I'll tell you. And then deploying the second one towards the 2 o'clock, and we're completing our procedure. And once we've deployed the stent and all, we come out. That's tightening our first suture at 10 o'clock. And once that is done, you go on to tighten the second suture. Surprisingly, the actual bleeding actually stops after the first suture, and second is more of a confirmation knot, or it's more of a, I would say, sort of, it gives you a relief that yes, it's tight enough. Being surgeons, we used to repairing it, and it's difficult to believe that it works, but fortunately it does work, and I've done it for 3 cases now, and all 3, the first suture actually stops all bleeding. You can keep your wire in while you're tightening the first suture, so that in case there's any issues and you want to go back in, you can at any time. And once you're satisfied, yes, the first suture has tightened well and is holding on well and the artery is clean, you can tighten up the first one completely, remove the wire, tighten up the first one completely, and go on to the second one. The second one is a reassurance knot. Believe me, it works very well. Then post-deployment, this is how the groin looks like. And we had a huge panel. We had a dynaplast holding her tummy up. But wonderful healing. The patient could actually walk the second day morning. We could have asked her to walk the same day evening, but and this is what the angio looks like. If you look at we've taken the angio from the left side, and if you look at the right side groin, it doesn't look as if anything has been done there. And it's as perfect as start. And this is immediate. Just we leave the first one, the first catheter in, just to make sure we take a good shot. Because I think this is something which I'll reiterate even later, that in case you find a minor leak, you can just give a good compression. If you find a major leak, you can always cross over and go on to the other side and put a stent graft in. And that solves the problem. And I think this is something which has been brought out in many trials. I think the recently concluded PVAR trial with Endologic's 21 French system, I think they were very categorical that yes, it works and it works well. The study objective was, of course, pre-close technique for femoral access. Enrolled around 192 patients, 20 US centers. And they went on to say, yes, the primary objective was achieved with a good p-value with major vascular side, no major, I would say, comparably, it's significantly lower ipsilateral axis vascular complications, and then similarly minor complications. And a lot of plus was, I think, the one was the procedure time, no need for a vascular surgeon. Being a vascular surgeon, that's a minus point, but yes, we do it ourselves, so it doesn't make a huge difference to us. But yes, definitely there's a time for hemostasis was less. And it does work. You need to have a good assistant on your other side when you're taking out the sheath and you're compressing it. I think that is something which we learned in retrospect, that being a huge hole, and by the time you compress and you pull the wire and pull the sheath, there is some blood loss. And probably that is one of the reasons why you'll find the blood loss is 200 ml on one and 280 ml on the other. Whereas I won't say our open repairs do not bleed that much, but this will, because there's a 20 French hole, which will take a few minutes for you to change sheets and exchange sheets, and that's where the blood loss comes in. I think that is something which we have to take into account, but otherwise, once it's sealed for good. And I think what's needed is you need to be very good in using per close on normal patient, on normal angioplasty, 6 French, 8 French, 12 French. And once you're very, very confident on that, I think move over to 21 French and any other sizes. You can even use 3 if you want. Different studies, everyone's saying probably reduced operative time, reduced groin complications, reduced time to discharge, and everybody is very happy with it. We haven't had experience with ProStar, but we had good experience with ProGlide, and I think that's what works in our hands. Again, from the net, manual for a minor leak like this, after a post-angio CT, probably compression. And if it's a major one, I think you need to use a covered stent. A lot of people have actually gone back and said, when you're removing it, especially if you're using a TIVA, you can cross over and place a balloon in your external ilex so that this bleeding part that I was telling you about stops. And I think that's a good suggestion. I'll probably use it the next time around. And I think that's where our future is, from open groins to closed groins. Thank you.
Would the panelists like to ask a question, please?
Yeah, just one methodological question. I saw the angiogram after the per close. Did you do an angiogram when you got access? Or did you have an angiogram before the per close?
Yes, we did.
Okay.
There is just one issue in our country, and that's the cost. We pay $590 some a piece for the ProGlide. So if you use 3 of them, 2 on one groin and 1 on the other, it's $1,500, almost $1,800. And that comes out of the DRG, and since the procedure is pretty expensive to begin with, the hospitals get annoyed if we do that.
Well, fortunately, surgeons don't come for free either.
Yeah.
So if you're going to charge bloody good price, if you're going to ask us for open a groin. If you're opening, as vascular surgeons, if I'm opening my own groins, then it's obviously less. But if a radiologist comes and asks me, open my groin for me, I'm going to ask him a good amount.
That's right.
So it's going to compensate for his ProGlides, I believe.
Yeah.
Is there an incidence of pseudoaneurysm, delayed pseudoaneurysm?
The literature does say yes, it is there, and like the last 2 slides that I showed you, there could be a minor one, there could be a major one. If it's a major one, you'll have to probably either do an open repair or put in a covered stent, which is actually a big drain. Putting in a covered stent is a much more costlier affair. But if it's a minor leak, you can probably just give a good compression and that solves it. It's just like any other pseudoaneurysm. And but most of the time, if you're really careful, you check it on table, it won't be there.
Yeah, I think even with the larger bleeds, if it's not a frank perforation or rupture, with the balloon occlusion and reversing the anticoagulation, that's all you need to do. So it'd be rare for you to have to use a covered stent, because again, you're adding another cost.
That's a big cost added.
Yeah,
that's a covered stent is a huge cost. Yeah. But I think any other thing, if you manual compression even afterwards, does the job. For minor leaks, at least.
Yeah, I mean, covered stents are good, provided your puncture is not is quite high up in the common femoral. Otherwise, you're going to cover the profunda.
Mm-hmm. Absolutely.
So
but
I think I think the best thing is to be more proactive and close it well. And I think that idea of going contralateral, putting a balloon and then checking it, if you have a bleed, you just inflate the balloon and do it. better.
I think the main idea here is that you have to be careful on where you puncture, which artery you puncture. There shouldn't be any calcification. All the complications or all the contraindications of using a ProGlide have to be followed to the book, because you're making a much bigger hole. There's a much bigger things at stake here. So for a normal 6-ring puncture, it doesn't make a difference. It doesn't make a huge difference even if you fail with a ProGlide, because you can always do a manual compression. But here you can't. So you have to be perfect in your punches. You have to be perfect in all your manipulations, because you don't want to constrict the artery. You don't want to rupture the artery. You don't want to open up any plaques or calcifications. I think that's where the main thing is.
Yes. So in my institution, we would routinely put a catheter from the contralateral side. And after we'll use a balloon occlusion while we're deploying the perclose to drop the pressure. And then once that's done, we deflate the balloon and do an angiogram. If we see that there's a leak, then we just advance the balloon and do a balloon inflation, for a minute or so. But we always open a balloon and have it in to occlude the external iliac before we even close the, with using 3 percloses on that side with the large sheath. The other thing that we do is that, the reason I asked about that, did you do an angiogram before, is that we'll do an angiogram. So we'll get access, and if we don't like the access, patient's not anticoagulated yet, we haven't put the large bore sheaths in, we pull it out and we start all over. I mean, we'll stick the same side, but we make sure we stick in the right spot.
Absolutely.
So the point you made about you want to make sure you're in the right spot, well, you make sure you're in the right spot before you, get into the game. So if you don't like the spot, just pull it out, hold pressure, and stick and start
Absolutely,
all
you're
over
right.
again. So there's no reason for you to be in the wrong place, because you have a chance to stop that, before it happens.
Absolutely, because the puncture near the profunda or gelling your profunda, gelling your SFA origin, I think that's a major worry. So your first puncture needs to be perfect. And if you're perfect, then you go on with your perclose.
Do you think ultrasound guided?
Absolutely. All punches are, especially for this purpose, all punches will have to be ultrasound guided. There's too much of things at stake here.
We've talked a lot about experience here. What you heard from Dr. Collins was the voice of experience this afternoon on that particular issue. Looking angiographically and having that balloon ready to go makes all the difference in the world.
Thank you very much indeed, Doctor, for your presentation on pre-close for